The following podcast is part of a certified educational activity titled A New Era of Migraine Management, Recent Updates on Recognition, Acute Treatment, and Prevention for Emergency Physicians. Access the entire activity and complete the post-test at peerview.com/VWY860. Downloadable practice aids and additional resources are also available.
Hello, I'm Dr. Benjamin Friedman from the Albert Einstein College of Medicine in the Bronx, New York. Welcome to this educational activity on current practices in recognition, diagnosis, and treatment of migraine for emergency physicians. Let's begin with a visual exploration of the differential diagnosis of migraine in the emergency department. So migraine is very common. You can see that among 40-year-old women, nearly 1 in 4 of them will suffer from migraine. The prevalence is a little bit less common among men, and substantially less common among elderly folks and younger kids. But still, this is a very prevalent disease, and therefore we see a lot of patients with migraine in the ED. So how often do we see it in the ED? Well, the vast majority of patients with migraine don't actually come into the emergency department for treatment of migraine. And looking at national data, we can see that of all the 30 million or so patients with migraine who are out there in the US, 94% of them do not use an emergency department or an urgent care for management of their migraine. Among the 6% who do use an emergency department or an urgent care for management of migraine, 5% of them will present infrequently with 1 to 3 visits annually, and 1% of them will present frequently. So patients who use the ED for management of headache are marked by several different characteristics. So they're marked by increased disease severity. So as with asthma and as with heart failure, patients who have worse underlying migraine are more likely to use the emergency department. Similarly, patients who have comorbid depression, patients with lower socioeconomic status, and patients who have a tendency to use the ED for other conditions are more likely to use the emergency department. We need to think about this when we have the patient sitting there in front of us. What are the patient's needs? What are the patient's goals? Are they there just for treatment? Are they there for reassurance that they don't have an underlying pathological process? Are they there because they're frustrated that their disease has been spiraling out of control? Every textbook that I've read on headache places headaches in different categories that are discrete and obvious. It's very easy to put every headache patient into one of these boxes. So, for example, this patient here has a migraine. This patient here has a tension-type headache. This patient has a headache due to sinus inflammation. This one has a headache due to elevated blood pressure. This one has a headache because of tumor or an aneurysm or meningitis. But that's not diagnostic reality. When we did a cohort study where we enrolled 480 patients who came to the emergency department for management of migraine, the vast majority of these patients had a primary headache disorder, be it migraine or tension-type headache or cluster headache. And some, in a smaller group of these patients, had secondary headaches. These were mostly benign, acute rhinosinusitis, cervicogenic headache, headache due to strep throat. But a large portion of the patients were unclassifiable. Despite spending a lot of time interviewing the patients and reviewing the patient's medical record, we couldn't assign them a primary headache diagnosis or a secondary headache diagnosis. So headache diagnosis in the ED setting can be challenging. Sometimes it's very difficult to come up with a specific reason why the patient is suffering that headache. But I'd like to encourage you to spend some time coming up with a specific diagnosis for the patient. If you can give the patient a diagnosis such as migraine or tension-type headache or cluster headache, then this is information that patients can use when they go out and leave the emergency department. They can research the headache, they can learn more about it, they can access care. Which patients who present to an emergency department need a head CT? A few decades ago, patients who came to an ED received some type of neuroimaging, either a CT or an MRI, about 12% of the time. Nowadays, that number is up to 1/3. As you might expect, the rate with which pathology is found on these neuroimaging studies has plummeted. 2 decades ago, about 10% of the imaging studies would reveal some type of pathology that required a specific action. Nowadays, that number is down to 4%. So 96% of the neuroimaging studies that are done in the ED setting are unnecessary. So who needs neuroimaging in the ED? There are some times when it's obvious. Clearly, patients with thunderclap headache need neuroimaging. Patients with focal neurologic findings certainly need neuroimaging. Then there are patients who clearly don't need neuroimaging. These are all the patients who come in with a typical exacerbation of headaches that they've had before. In these patients, clearly obtaining neuroimaging is just a waste of time and resources and doesn't do the patient any good. We know that age over 50 is a risk factor for finding pathologic processes. but we don't have clear guidelines for when to image younger patients who have a headache that's somewhat different than the headaches that they've had before, or a headache that's a little more intense than they've had before. And a strategy that I use, that I encourage you to adopt, is to treat the patient. Assume that they have a primary headache disorder and treat the patient. Many times after I've given the patient something for their headache and go back to evaluate them an hour or 2 hours later, they'll say to me, "Doc, I'm fine. In retrospect, that headache was just like all the headaches that I've had before." There's nothing like having a headache relieved to put it in perspective with the headaches that patients have suffered previously. There are some clinical decision rules that can help us decide which patients need a workup. And specifically, I'm talking about the Ottawa subarachnoid hemorrhage rule. There's a 6-item clinical decision rule. So these are patients who present with a severe non-traumatic headache that peaks in intensity within 1 hour. And if they have a completely negative rule, negative on all 6 items, then they don't need a CT, they don't need an LP, they don't need neurovascular imaging. They're good to go home with just appropriate treatment. Obviously, besides subarachnoid hemorrhage, there are a whole host of subtle secondary headaches that emergency physicians need to diagnose. Venous sinus thrombosis won't be apparent on a non-conscious head CT, and so the emergency physician should consider it in anyone with a headache and thromboembolic risk factors or recent head or neck surgery. As with DVT and pulmonary embolism, a D-dimer is best used to rule out patients at lower risk of disease. Idiopathic intracranial hypertension or pseudotumor cerebri is tricky because it often has an overlapping clinical presentation with migraine, particularly young, relatively healthy women. Be sure you don't confuse transient visual obscurations for aura, because this can be a telltale clue about what the patient's true diagnosis is. Unfortunately, our retinal exams are not what they should be, so I often will dilate the patient's eye to ensure that I can rule out papilledema. Alternatively, one can use the sonogram to measure the optic nerve sheath diameter to help rule out elevated intracranial pressure. Cervical artery dissection can be very subtle, particularly before neurologic signs develop. Here too, the ultrasound can be your friend to help make a quick diagnosis of dissection. And fever and headache is always difficult for emergency physicians. It's clear that the overall prevalence of bacterial meningitis is much lower in our current age of vaccinations. And it's clear that most patients with bacterial meningitis present delirious. Therefore, in a fully alert patient with fever and headache, you can often observe the patient in lieu of a spinal tap until you are sure that the patient does not have a bacterial source. This, unfortunately, does not apply to immunocompromised patients, in whom you must have a very low threshold for spinal fluid sampling. Once you've ruled out a secondary cause of headache, how do you go about assigning a specific diagnosis to the patient? It's useful to assign the patient to diagnosis to help them access care down the road, to help them educate themselves about their diagnosis, and to help them figure out what medications are most appropriate for themselves. There are several tools that have been used to help, but in general, if a patient presents to an emergency department with a headache that's severe and functionally impairing, gets in the way of them doing their usual daily activities, the diagnosis most likely is migraine. Tension-type headache does indeed present to the emergency department, but it's usually mild, rarely impacts daily activities, and often patients with tension-type headache present to the emergency department simply because they want to be reassured that something bad is not going on. Cluster headache is usually obvious because it's so severe. Patients are often pacing, they're agitated because the pain is so bad. Cluster headache typically lasts no longer than 3 hours. By the time a patient develops the headache, gets themselves to the emergency department, registers, triages, and sees the emergency physician, for the most part, the headache is resolving or resolved. It's important for the emergency physician to make the diagnosis of cluster headache because cluster, by its very definition, will come back the next day. Let's discuss the different phases of migraine headache. For the most part, when emergency physicians see patients with migraine, they're in the middle of the headache phase. The horrible pain is what drives the patients to the emergency room most frequently. Hours or days before the attack, migraine patients experience a prodrome, which can include a range of symptoms such as tiredness, moodiness, or food cravings. Up to 75% of migraine patients will experience a prodrome, but it's often not recognized because it's relatively subtle and not the driving factor that brings the patient to the emergency department. An aura occurs in about 15% of patients with migraine. Typically, an aura will begin before the pain begins and resolve just as the pain is beginning. Most commonly, the aura presents with visual changes, such as flashes or blind spots, but it can also present with other neurologic symptoms, such as numbness or tingling. The headache phase typically lasts hours to days. Migraine usually presents with nausea and sensitivity to light and to sound as well, although you don't need these features to make the diagnosis of migraine. And then finally, once the headache phase resolves, there's a postdrome, otherwise known as the migraine hangover. And it's experienced by up to 80% of migraineurs, and it's characterized by a weariness or a drowsiness. They're just relieved to be done with the headache and sort of don't really have the energy to do much else. So there are international criteria for the diagnosis of migraine. Features of the diagnosis include unilateral location, a pulsating quality, a headache that's moderate or severe in intensity, or a headache that's aggravated by or causes avoidance of routine physical activities. Also, migraine typically presents with nausea or vomiting and photophobia and phonophobia. What we find is that many times patients with migraine will present with some but not all, or sometimes even very few of these criteria. But again, know that if a patient presents with a severe headache in whom you've ruled out pathologic causes, migraine is almost always the correct diagnosis, and these patients should be treated as such. Episodic migraine is defined as fewer than 15 headache days per month. Chronic migraine is defined as 15 or more headache days per month. Chronic migraine is a horrible disease that affects about 4% of the US population. It's all-encompassing, taking over a person's life, affecting their work, their social engagements, and their household chores. Emergency physicians should do everything that they can to prevent patients from getting chronic migraine and to help patients with chronic migraine revert back to episodic migraine. Actions that the emergency physician can do are appropriate use of medication, education, helping the patient identify triggers and factors that make their migraine worse, and ensuring that the patients have appropriate outpatient care. In the next part of this activity, we'll examine approaches for treating migraine in the ED and considerations for multidisciplinary care coordination. The good news about management of acute migraine in the emergency department is we're getting better at it. We're not using IV opioids nearly as frequently as we used to. And increasingly, we're using medications such as the antiemetic antidopaminergics as primary treatment of migraine. Use of nonsteroidals for treatment of acute migraine is also very common. Use of triptans, however, is quite low. Besides triptans and ergotamines, there are two new classes of medications with established efficacy in the acute treatment of migraine that we should be aware of. CGRP is a key neuropeptide involved in pain signaling during a migraine attack. Activation of several serotonergic receptors can block the release of CGRP, other neuropeptides, and neurotransmitters, and can relieve the symptoms of migraine. Triptans and ergots work through serotonin 5-HT1B1D receptors, but they cause vasoconstriction, which can limit their use because they have the potential to cause cardiovascular harm in some patients. Unlike 5-HT1B receptors, the activation of 5-HT1F receptors with the 5-HT1F agonist does not cause vasoconstriction, nor do the CGRP receptor antagonists. The evidence for subcutaneous sumatriptan is pretty strong. Meta-analytic data indicate that the number needed to treat for 2-hour pain relief for subcutaneous sumatriptan is 2, which is a phenomenal number. And we can see from ED-based data that nearly 75% of patients who come to the emergency department with migraine and are treated with subcutaneous sumatriptan will achieve meaningful relief. In fact, the median time to achieving meaningful relief after receiving subcutaneous sumatriptan is 34 minutes. And so what that means is you could sit a patient in a chair, give them a subcutaneous injection of sumatriptan. They don't need an IV line. They don't need a cardiac monitor. They don't even need a stretcher. You can give them the injection, and 34 minutes later, half of them are ready to return to work, which is phenomenal. The problem with subcutaneous sumatriptan is a 24-hour recurrence rate, which is substantial, and also the adverse effects that we see. In fact, the number needed to harm for subcutaneous sumatriptan is 4. For the most part, these symptoms are nuisance symptoms, dizziness, nausea, paresthesias, but patients sometimes really don't like the experience they have with subcutaneous sumatriptan. Sometimes they'll get palpitations or flushing or worsening of their headache. And so really, I reserve subcutaneous sumatriptan for patients who've had a good response to it before. Another consideration when it comes to triptans is all the second-generation oral triptans. So these medications are quite effective. And again, you could sit the patients in a chair, give them an oral triptan, and then within a few hours, many of them will have headache relief and be ready to go. The data for the antidopaminergics, the antiemetics such as metoclopramide or prochlorperazine, is quite strong. There's a host of comparative effectiveness research demonstrating that these antidopaminergics are as good, if not better, than subcutaneous sumatriptan, the putative standard of care. When choosing among the various antidopaminergics, one can consider the patient's experience with the medication previously and the side effect profile. Prochlorperazine is highly effective for acute migraine, but comes with a lot of extrapyramidal side effects that require treatment with diphenhydramine. Metoclopramide is better tolerated, but probably not quite as effective. Increasingly, I've been using greater occipital nerve blocks with bupivacaine for treatment of acute migraine in the emergency department. Theoretically, by decreasing the impulses through the greater occipital nerve, one is decreasing the nociceptive pathways, or the impulses through the nociceptive pathways of migraine. Whether or not this mechanism is true is still yet to be determined, but increasingly, clinical data indicate that the greater occipital nerve block in experienced hands is effective for terminating acute migraine. Dexamethasone is a medication that's underused for management of migraine in the emergency department. One of the biggest problems that patients with migraine have after they leave the emergency department is recurrence of headache within 24 or 48 hours. And dexamethasone clearly decreases the frequency and intensity of headache after ED discharge. Lasmiditan is an orally available selective 5-HT1F receptor agonist that improved headache freedom at 2 hours versus placebo with a number needed to treat of nearly 6. Long-term treatment with lasmiditan reduced migraine-related disability, including both work or school absenteeism and presenteeism. CNS adverse effects were common, including dizziness, paresthesia, somnolence, fatigue, nausea, lethargy, and vertigo. Another group of novel medications for acute migraine are the CGRP receptor antagonists. These medications aren't quite as effective as lasmiditan, with the number needed to treat of about 10, but they were better tolerated. And so these are useful medications to have in one's armamentarium when one's treating acute migraine. When do you consider patients for admission to the hospital? If patients have pain refractory to ED management. Now, I have confidence that emergency physicians, with this large armamentarium of available medications for the acute treatment of migraine, most emergency physicians will eventually be able to effectively treat acute migraine. But too often we have time constraints and busy EDs, and so sometimes it's best to pass along the management to the inpatient team. In patients with true status migrainosis, that is, a headache that is severe, unremitting, and refractory to medication, or patients who have social circumstances that are causing their headaches to spiral downward, these are patients who are best admitted to the hospital so that the patients can be established on a better pain trajectory. Patients who are dehydrated or unable to tolerate oral medication are best admitted to the hospital. Now, again, many times these patients can be adequately managed in the emergency department with intravenous rehydration, but sometimes for social reasons, patients are better served by being admitted to the hospital. And finally, complicated chronic migraine should be admitted to the hospital when it's accompanied by psychiatric comorbidities and medication overuse headache, because these patients are very difficult to manage in the outpatient setting. So how do I treat acute migraine? I start with metoclopramide, 10 milligrams IV, and I add dexamethasone along with that. If the patient isn't any better after that first round of treatment, then I'll give another round of metoclopramide and add ketorolac. There are some patients who aren't better after that, in which case I'll add dihydroergotamine after the metoclopramide. And failing that, I rely on the greater occipital nerve block. Now, there are some patients in whom I'll do the greater occipital nerve block right up front, but often patients are a little bit reluctant to receive a needle in the back of the scalp, even if you can assure them it'll do some good. Increasingly, I'm using the novel agents for patients who are refractory to standard treatment. And finally, I rely on propofol if nothing else works. And finally, I don't use opioids. I recognize that opioids are still commonly used in many emergency departments across the country for management of migraine. But with the wealth of data supporting other medications for acute migraine, there is almost never a need to use opioids nowadays. Let's discuss a case. This is a 36-year-old woman who presents to the emergency department with her typical migraine headache. She reports about 12 days of migraine per month. She reports that sumatriptan and ibuprofen usually give her relief, but she's forced to visit the emergency department about twice per month for severe migraine refractory to oral treatment. She presents with pain that's 10 out of 10, severe, for 6 hours. And when you go to evaluate her, she says, "Doc, just give me my Dilaudid." So opioids are never appropriate for first-line treatment of migraine in the emergency department. Opioids are associated with a host of negative sequelae, such as recurrent ED visits and transforming episodic migraine into chronic migraine. For this patient, I would use many of the medications that I've discussed previously. I would start with the antidopaminergics. I would consider using nonsteroidals. I would see if triptans have a role. Perhaps this patient is appropriate for a greater occipital nerve block. Perhaps one of the novel agents, such as the serotonin 1F agonist, lasmiditan, or the CGRP receptor antagonists, would be appropriate for this patient. I would also screen to make sure that this patient is receiving appropriate outpatient care. Perhaps she's somebody who would benefit from a preventive. Perhaps she's somebody who doesn't have access to a healthcare provider who can help her manage her migraines in the outpatient setting. Be sure to spend time with this patient, educating her about triggers, helping her discuss what brings her migraine on, and seeing if I could help her come up with another solution to better manage her migraine. It's important for the emergency physician to understand what happens to our migraine patients after they leave the emergency department. We know that many of our patients continue to suffer over the days and weeks after they leave the ED. For example, we know that many of our patients suffer aftershock headaches during the week after they leave the emergency department. Patients report on average 3 headache days during the week after they leave the ED. We also know that patients suffer substantially in the 48 hours after they leave the emergency department. 50% of patients report functionally impairing headaches in the 2 days after they leave the ED. 2/3 of patients who are successfully treated in the emergency department report recurrence of headache, and 1/3 of those patients report headaches that are moderate or severe. And what about preventives? Who are the migraine patients who need a preventive, and should an emergency physician ever start a preventive in the emergency department? So the patients who need preventives are patients who are suffering with lots of migraines. And if patients start having more than 1 or 2 days of migraine per week, then one should certainly consider starting a preventive medication on them. For the most part, this is a responsibility for outpatient medical providers. But there are patients who are unable to access care, present to the emergency department preferably, who keep coming back despite effective acute treatment, and these are patients in whom I'll often consider starting a preventive. There are various different classes of medications that can be used to prevent migraine. The antiepileptics are often used. Beta blockers have a role. Botox is increasingly used in this regard. The antidepressants are probably effective for preventive treatment of migraine. And finally, there's a whole new class of medication. These are anti-CGRP monoclonal antibodies, which have an important role for the preventive treatment of migraine. These are evidence-based medications to prevent migraines from coming. For the emergency physician, because of the medications that we're familiar with, beta blockers such as propranolol or metoprolol are probably the best medications to initiate. Alternatively, an antidepressant such as amitriptyline is a reasonable choice for an emergency physician until follow-up with an outpatient provider can be arranged. More and more of our patients will be using anti-CGRP and CGRP receptor monoclonal antibodies to prevent migraine. Multiple studies have demonstrated reduced migraine days in patients who have not had success with other preventive therapies. Reduced healthcare resource utilization, including statistically significant reduction in ED use, has been observed with these meds. It's important for the emergency physician to provide the patient with tools to treat these headaches after they leave the emergency department. This starts with administering dexamethasone for patients in the ED, and then providing the patient with prescriptions that they can use when they go home. Nonsteroidal anti-inflammatory drugs and triptans are reasonable first-line medication for use in this role. Agents with recognized efficacy for acute treatment of migraine include general analgesics and migraine-specific treatments such as ergots and triptans. Also, newer classes of migraine-specific agents include CGRP receptor antagonists and a 5-HT1F receptor agonists. Finally, it's important for the emergency physician to provide the patient with a provider that can help the patient manage their ongoing headaches. In an effort to ensure sustained relief from post-ED headache recurrence, providers should always consider discharge medication and education, and these will help reduce the need for a repeat ED visit. In summary, emergency physicians have an opportunity to impact the ongoing care and lives of their patients with migraine. Significant advances in migraine treatment have yielded a range of treatment options for addressing patient needs, and migraine management often starts with emergency physicians, placing them in a key position to facilitate ongoing treatment. I thank you very much for your participation and for your attention to today's program.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/VWY860. This activity is supported by an educational grant from Lilly. For further information concerning Lilly grant funding, visit www.lillygrantoffice.com. This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.